everyone. You are here at the Yale Alumni Nonprofit Alliance program on the COVID vaccine rollout program. We are hosting primarily through the YANA New England chapter, but also in conjunction with our Yale Club of Houston. Ed Hers, our main guy in charge down in Houston, had a conflict this evening. So even though I'm not physically sitting in Houston at the moment, I am going to be representing the Houston crew. So welcome from both parts and all parts of the country and the world. We have a terrific program this evening. I'm going to hand the microphone off to Joellen Gray, who is an SOM grad and one of the heads of our New England chapter, who will tell you all about the program and our speakers. This is being recorded. We will monitor the chat and the Q&A functions. And to the extent that our moderator and our panelists are unable to reach all those, we'll do our best. We've received some ahead of time, but otherwise I will keep my eye on the program in the Q&A in the chat below. So thanks very much. And Joellen, back to you.
Great, thank you so much, Rachel. So the global COVID-19 vaccination rollout is one of the largest healthcare initiatives ever undertaken. In the US, these rollout efforts have stumbled as deaths continue to climb and new variants of the virus expand, further straining our healthcare systems. The first phase of the vaccination, targeting hospitals and long-term care facilities where eligible people were concentrated, was relatively easy to implement. Truly the hardest work lies ahead. Some 150 million Americans are now eligible, as Vaccination Priority has been expanded to include people ages 65 plus, those with high-risk medical conditions, and other essential workers. And vaccination supply may not meet demand until summer. Meanwhile, many state deployment efforts have stumbled with difficult to navigate portals, complex eligibility rules, poor communication, and quite honestly, many individuals don't know how to sign up and what will happen after they do. And the race is on to complete this process before virus variants that are resistant to the vaccines take hold. We've asked this panel of very distinguished healthcare policy leaders to share their perspective. And I'm going to ask you each to raise your hand. Dr. Peter Hodust, he is scientist, researcher, author, and science explainer. Many of you have seen him on CNN and MSNBC. He's the Dean of National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at the Baylor College of Medicine. Dr. Bettina Experton is the CEO of Humetrix, doing work for the Department of Defense, tracking virus hotspots and monitoring vaccinations among the 65 plus Medicare population. And Dr. Saad Omer is the Inaugural Director of the Yale Institute for Global Health and has an amazing perspective on what's going on everywhere else in the world. Our moderator this evening is Dr. Sten Vermond, who is the Dean of the Yale School of Public Health. And just thank you all so much for donating your time. Thank you as well to our sponsors in the chapters of both New England and Washington, DC, and to the Yale Club. And a special thanks to Rachel Littman and our founder, Ken Inadami. And with that, Stan, I'm going to turn it over to you.
Thank you very much, Rachel, Joellen. We appreciate the invitation. And what we thought we'd do is an icebreaker, 5+ minutes of each of our speakers to talk about issues they think would be of interest to you. We've also assembled the questions that you've been sending in, so we will try to get to as many of them as we can. So I'm going to turn first to Peter Hotez. Peter actually went to Yale, so he is an alumnus with the rest of us, and we'll look forward to his comments. Peter, you're on mute.
Yes, thank you, Stan. Yes, I did go to Yale as an undergraduate, class of '80 in Trumbull College as an MB&B major, and then came back for round 2. I was a postdoc on the faculty for 11 years, so I spent 15 years of my life in New Haven, and a city I've come to love, and a university that I've always loved, and I've got my blue sweater on to prove it today. A few things to talk about. I think one, when it comes to vaccines, one of the things that I always point out with, we've been developing coronavirus vaccines for the last 10 years, and we took it on because we'd been developing vaccines for neglected diseases. I've been doing this for 40 years. I'm an MD, PhD laboratory investigator and vaccine scientist that was focused mostly on parasitic disease vaccines. And then about 10 years ago, we got approached by a group from the New York Blood Center that had some ideas for a coronavirus vaccine. Even though we weren't virologists, we took it on as an orphan project because nobody cared about coronavirus vaccines for the same reason nobody cared about parasitic disease vaccines. There was no obvious financial market. So we took it on and showed how the spike protein is the soft underbelly of the virus, how there are ways to deliver the spike protein. And that led to first generation vaccines for SARS and MERS. And I tell you that story because when the COVID-19 sequence came out, we basically said, we got this. And now we're developing a recombinant protein COVID-19 vaccine that's being scaled in India. They're producing 1.2 billion doses because there's an alarming absence of low-cost vaccines for global health for COVID-19. But I also tell the story because one of the central tenets of the anti-vaccine movement, which has become so powerful, and is my other role because I have a daughter with autism who actually was first diagnosed at the Yale Child Study Center way back when. And I wrote a book called Vaccines Did Not Cause Rachel's Autism to go up against very aggressive anti-vaccine movements. Is one of the things they say is the COVID-19 vaccines are rushed and not adequately tested for safety. I point out, look, this is a project that's not been done in a few months. It's a 10-year R&D effort, and I think it's important people understand that. So we're now scaling production of our COVID-19 vaccine, and in the meantime, I'm concerned. I'm concerned that we thought we kind of had our arms around this a little bit. We were scaling up vaccines. There was a good portfolio of Operation Warp Speed vaccines. We were contributing to the Global Health Initiative for COVID-19 vaccines. And now we have something called variants. And the UK variant is worrisome enough because it's spreading across the US at an alarming rate. And so that we're going to see now a steep increase in the number of COVID cases. And now the South African variant, which is thwarting some of our efforts to develop vaccines. So this has turned what's already been a year-long global health crisis into something even more ominous, and how we get our arms around it to combat it will be a good topic for our discussion tonight.
Thanks, Peter. Great way to open it up. And I'm going to ask Bettina Experton to take it from there.
Thank you, Peter, and thank you, Rachel and Joanne, for inviting me to join this panel and have this important discussion today. So by training, I'm a health services researcher, public health physician, epidemiologist, but what I can share with you today is more so of what has been our experience. My experience as a CEO of a digital health company was called early in the pandemic to basically pivot right away, responding to a call from the Department of Defense, who had a humanitarian support mission with regard to COVID-19, and was noticing that the most affected individual here in the US, as elsewhere in the world, by the disease were the elderly. So Humetrix was asked to put its platform to use to understand who was really at risk for COVID-19 in terms of hospitalization or deaths among the elderly. And so we put our platform to use to just do that, and we risk profile that patient population so that the vaccine, the scarce dose of vaccine available initially could be prioritized for people more at risk. So I have a few slides to share. And let me share my screen. If everyone can see my screen. So
Yes.
this particular project of the Department of Defense, and specifically the AI Excellence Center of the Department of Defense, called the Joint Artificial Intelligence Center of the DoD, put in place this COVID-19 dedicated project called Project Salus. Salus is a name, the Roman goddess for health and safety. And so our role at Humetrix was to develop a risk model for severe COVID-19 in that higher risk patient population, 65 plus, who is now targeted to receive the vaccine in priority. And we want to get that critical data from the Medicare program. And as of today, over 17 million Medicare beneficiaries are in this Medicare beneficiary cohort. We are monitoring, receiving over 100 million claims every day, and which our platform analyze. And in that cohort, 1.9 million developed COVID and contributed over 50% of total US hospitalization and 63% of COVID-19 related deaths. So we applied logistic regression analysis and artificial intelligence analysis to risk profile this population. What specific risk factors, being comorbidity, medical diagnosis in this Medicare population, the data coming from Medicare claims, as well as the social determinants of health, the social demographic risk factors. How do those risk factors in combination contribute to severe COVID, and how can we risk stratify that population in terms of risk? So on the right here, from low to high risk in this map in the lavender color, the darker color corresponds to those high risk area where you have more individuals with a higher risk to develop severe COVID, being a risk to be hospitalized or dying from the disease. And this histogram on the left shows a distribution of this large cohort in the Medicare population according to risk, and that stratification can be used to preferentially allocate those scarce first dose of COVID-19 vaccine to those higher risk individuals. So here's an illustration on how this map works, and this is a live dashboard used by the military. The National Guard were again deployed, and now active duty military were deployed to set up mass vaccination site. This is the Los Angeles metropolitan area, and you see that there is quite a variation down at the zip code level in terms of the risk of that population of individual over age 65. Higher risk in central LA and East LA. And when we overlay over this risk map, the case hospitalization rate in those orange circles, the darker circle being the highest risk rate of hospitalization in that population, you could see that there is indeed a correlation, apparent correlation between higher hospitalization as we observe them over the last 12 months and the higher risk area. We also conducted a quantitative analysis to verify this correlation. This is the linear regression graph we have on the right, showing all the zip code in those red dots in the Los Angeles metropolitan area. And there is a high correlation between our calculated risk and what we observe in terms of hospitalization. We also conducted this risk model for death, and we verify this high correlation in all metropolitan areas in the US. So here's again this risk map nationwide, and we compare that risk map with the CDC Social Vulnerability Index, which is used today by some states and county health departments to try to allocate those vaccines to the individual most at risk in terms of their socioeconomic risk. However, this SVI map is for the general population. It has not been validated for COVID-19 as we did. It's not for the 65 plus. And if there is some resemblance between those two maps, there are some discrepancies. So higher risk area in the SVI map may not be at higher risk when it comes to COVID for that 65 plus population. So drilling down to specific area, starting with Houston, Peterstown, so you can see that risk map, who is going to, where those elderly over 65 may develop severe COVID-19 and be more likely to be hospitalized once they are infected with COVID. And again, with the SVI, you can see that if there are resemblance in the center of this area around downtown, in the periphery, which shows like higher risk in dark blue, this peripheral area are not at higher risk with regard to COVID for the 65 plus population. So this is the dashboard the military are using, monitoring the pandemic in that population, showing all cases in red, showing their hospitalization, their ICU admission with time series, ranking those counties in terms of case count. And now going back to the hospitalization rate, we have now on a vaccination tracker map, we have overlay over that risk map, the vaccination rates by county and down at the zip code area. Those are the green circle. And the larger the circle, the higher are those vaccination rates per 100,000 individual. So again, so what is interesting to see is whether or not those vaccinations are taking place in the highest risk area as we measure those. Here is Boston. And again, the higher risk area on this part, darker lavender color, doesn't seem to be receiving the higher rate of vaccination, whereas lower risk area with larger green circle are getting more vaccination. And this pattern where we see that vaccination are not targeted to the highest risk individual is seen everywhere. This is Phoenix. This is Detroit. In Detroit, it's slightly better, but you see again that the larger green circle are outside those higher risk area. This is the Bay Area in San Francisco, Oakland, and the higher risk area of Fresno County, again, is not served by vaccination. And the lower risk area of Marin County, for instance, see a higher rate of vaccination. This is Los Angeles, downtown LA and East LA are not vaccinated in priorities, and lower risk area are. Interestingly, one of the 100 mass vaccination sites, the President Biden COVID-19 task force want to set up, one of the first one is going to be in that East Los Angeles County area. This is, here we are in Texas. This is San Antonio. This is Austin.
Dr. Experton, can you mind if this is Peter, can I ask you a quick question? Because this came up this morning and yes, it may be relevant. So on that very important academic forum known as Twitter, I got asked by Scott Gottlieb, who's the former FDA commissioner. You know, he said, now that we have the UK variants here in a big way, shouldn't we be rushing vaccines to those sites where the UK variant is emerging and focusing all of our vaccinations there in order to try to limit spread of the UK variant? I said, it's an interesting idea, Scott, but the issue with it is we're so underperforming in terms of genomic sequencing that, you know, I think we only know a fraction of the places where the UK variant is here. But he does bring up a good point. Should we be overlaying, for instance, and now that I'm hearing your talk, should we be overlaying where assuming that we can do better in terms of genomic sequencing, should we be overlaying onto your maps the UK variant and where it's popping up, and using that as a part of our prioritization scheme.
And yet, if we had, the ability to sequence everywhere, this would be great. And I will totally agree with the approach, Peter. I think we have another way to maybe pick up where these new, more contagious variants may appear. We have, in Project Salus, we have developed predictive model with a 4-week forecast of where we see the pandemic picking up. And our partner Amazon in Project Salus has just done that. And in fact, they were reporting this morning that they were concerned about various counties in Texas where they were noticing, a growth in spread. So in terms of their 4-week
that's
forecast.
Interesting. By the
So
way, we
that's
just
another...
the headline news tonight is that now we have the South African variant in Houston, Texas, and
so one way to
concern.
Yes. So with this lack of nationwide sequencing abilities, at least if our forecast or predictive model with regard to the pandemic can direct additional sequencing and then to direct vaccination on top of what we are discussing right now, which is the risk map. I would like to show you also this map. We have created for the DoD a vaccination ethnic inequity. So in those areas which have been vaccinated, our vaccine, equally distributed, are all, ethnic group as served equally or not? And the answer, as Stan, you introduced this talk with, they are not. So in this orange, red color here, we are showing areas where minorities, Latinos, Hispanic, Black, and so forth, are less vaccinated than whites. When you have a reverse trend, we are into the blue. And so any of this orange area, from darker red, darker orange to lighter orange, are areas where there is inequity in terms of vaccination according to race or ethnicity. And we have a ranking here by counties of those areas from worst to best. So, to try to target community and outreach to those communities, this map is also of use for this purpose. On one side, you can, with a prior map, you can see what areas have been served and not well targeted according to risk. With this map layer, we can also address the diversity issue and the inequity issues in terms of some of our community of colors. And this is
Thanks, Bettina. We're going to have to wrap you up and get to Saad in a moment.
Yes, and that's in fact, and my presentation. Right
Oh,
here.
I'm sorry.
That's okay.
Shortcut your last slide. I didn't mean to do that.
No,
All right, thank you. That was fascinating. Let's turn to Saad Omer for his opening comments.
Yeah, so thanks for the opportunity to share some of my thoughts on vaccines, etc. I've been working on vaccines for a while. When this pandemic started, I got involved with several of these issues. I'm not going to cover not only just from my perspective, but also not the full set of things we have been doing here. But I'll talk about, I'll start the discussion by like 3 aspects. So I've had the privilege of being part of the WHO SAGE working group on COVID-19 vaccines and worked on initially. So that process started with, actually in summer and actually late spring, but with full speed in the summer to start to prioritize who gets the vaccines first, second, third, etc., and develop a framework. But before that, we said that we need to state a values framework so that countries, when they make their decisions, know what ethical principles to ground their approaches in. We did that. That was a mix of ethics and applied public health. And then we developed, and where I co-led the development of the global prioritization framework, where we said that without knowing the details of the vaccines, because the trials hadn't come out, we knew some basic characteristics, but not the efficacy, etc. What populations countries should prioritize. As it turns out, the US is now sort of coming back full circle and aligning fairly closely with the WHO prioritization framework, which articulated a mortality-first strategy with the assumption that, and I would submit the correct assumption that we will not have enough vaccines to meaningfully interrupt transmission. And coming back to what you raised, Peter, that in order to have an transmission interruption strategy, you need a reasonable level of vaccination to make an impact. So therefore, the choice at this point points to a mortality-first strategy, because mortality is irreversible. Sorry, if it were reversible, that we would have other headlines in the newspaper. But mortality is irreversible, and the most irreversible of the outcomes. You can have an economic stimulus to reinvigorate the economy. You can add an extra semester to catch up on education and do other interventions, although not perfectly. But mortality is the most irreversible outcome out there. And so based on that, and based on some of the other considerations, an overall approach was developed, which says that when the doses are limited, go to the highest risk groups for mortality and slowly build out towards preserving the social function outside of that, sort of once you have covered that, as you start covering that. So the other irreversible outcomes are child development. So in the second stage in that framework, education workers and teachers, etc., fare well. So with that work, we have been following. Now the work is on clinical recommendations, vaccine by vaccine recommendations. And the third one will come out later this week. We've had, through the WHO work, 2 of the recommendations, one for Moderna, one for Pfizer, and then clinical recommendations of how the world should use it. Switching gears, I was involved with a similar line of work as part of the National Academy's work in the US, and was part of their committee to develop the overall allocation framework. And there were similarities between the two, but there were differences. But one of the things that was a feature, and that Bettina alluded to, is explicitly ensuring that access is grounded in social vulnerability. So the concept that we developed in fall, that irrespective of who gets to prioritize first, gets to be prioritized first, second, third in terms of their risk groups, at every group level, access should be monitored based on the social vulnerability index, which has 15 variables, can be calculated at the census tract level up, and includes some of the most important social determinants of health. And so that was an early signal towards equity. So this came out in early fall, and then was adapted and adopted by sort of entities ranging from CDC through state governments, etc. The third thing that I will specifically focus about is some of the work we have been doing, interdisciplinary work based at Yale and with other partners on vaccine acceptance and demand. We were early proponents of planning for acceptance and demand related interventions because we knew that it was a bit almost Pollyannish to believe that everyone will sort of accept the vaccine right away, because that's not the case. And I can go into the details of why we thought what we thought. So we started doing, among other things, a series of studies in collaboration, so it's collaborative work with Yale social scientists and economists and us. The first one I will mention is that we earlier on did this study where we randomized people into, experimentally into the approval period of vaccines. And so we anchored it a week before the election. We mentioned both the date and the election significance, and on December 9th or 10th, because we thought that if things were, if they allowed to let things take their course, that would be the actual approval. And not surprisingly, but interestingly, what we showed that the acceptance just by changing the date of approval. So remember that we were doing this in August, well before the full-on pushback came, or around the time when there was a push to FDA to, some would say, unduly accelerated to match the political timeline of the vaccine approval. And we found that just by following the process of fast but rigorous review, meaning in terms of timeline of having an approval date of December, just varying that quantity, there was an increased acceptance of the vaccine. We also randomized people into what we call elite endorsers, and did several sort of sub-experiments, and we found two lessons, we had several lessons from that experimental work. But we found, first of all, that if the most valued endorser, and this was again early fall, was Dr. Fauci, Tony Fauci. If he had said no, that this vaccine is iffy, the program would have been doomed. But his positive endorsement was not only appealing to Democrats and independents, but also Republicans, although less so. And so he had broad appeal, but varying appeal. But also we found that political leadership endorsing it would be helpful, but only if it's bipartisan. In fact, you could have a backfire effect if one side is endorsing it strongly than the other. So we have been working on other experiments, etc. We did a model, we proposed a model for mandates and how to have evidence-based mandates as behavioral interventions, not as draconian interventions. And then we did some work on that showed that, again, this is from a couple of months ago, but the idea we showed was that if a country, once it is close to its own herd immunity threshold, it's in its interest, even before that, to ensure other countries also have high immunization rates, because now it's fairly obvious. It wasn't that intuitive at that time because, for example, the likelihood of variants emerging outside that are resistant to the vaccines that you have deployed in your country are also, is a threat to even the country that has almost unilaterally vaccinated a high proportion of its population. So this vaccinating everyone is in everyone's enlightened self-interest. So I think my 5 minutes are just up, so I'll pause here.
Thank you, Saad. Thanks very much. I think we'll go back to Peter, and a number of questions from the audience came in before the webinar asking for you to review some of the basics regarding the vaccines. How do they work? Does it prevent infection or simply guarantee a less severe reaction? When can you count on efficacy post-vaccination? When can you count on protection? How long is protection going to last? Can you still become an asymptomatic carrier even if you've been vaccinated? And once you're vaccinated, what can you do and what shouldn't you do?
Yeah, so a lot there. I don't know if we can spend 2 hours doing that, but let me see if I can sort of cherry pick a little bit and also address Saad's, an important point Saad made, which is, and Saad and I, for full disclosure, are working on this very interesting Lancet commission around vaccine hesitancy in the US. But, I think one of the themes I think that's emerging, and I'm like all of us, I'm on Zoom calls all the time, but I think something that's very clear is that the US vaccine strategy right now is trying to be everything to everyone. And it's clear that when you're rationing vaccines, at some point, we're going to have to make some tough decisions. So, what is our goal in the US national vaccine program, at least in the early days? Is it to save lives and reduce hospitalizations? Or is it to halt virus transmission? Or is it to open up schools? Or is it to open up the economy? And the truth is, the way you would structure vaccine prioritization, and Bettina, I'm sure, would have something to say about that, really can affect the outcome of that. And I think one of the things that so far the Biden administration has been doing is, wants to do it all. And we can do it all, but we're not going to do it all in the next few weeks with rationing of vaccines and limited availability. As vaccines become available, the J&J vaccine, and eventually the AstraZeneca Oxford vaccine, which will get released through emergency use authorization, the Novavax vaccine, then we can be everything to everybody. But for now, it's not the case. So I think that's an important point to make, and maybe we can have some discussion about that. But in the meantime, in terms of how these vaccines work, they all work the same way. They all work by inducing high levels of virus neutralizing antibody. And I'm often asked, hey, doc, which vaccine are you waiting for? And I'm not. I wound up taking the Pfizer vaccine only because it was the first one offered to me. I would have taken any of the Operation Warp Speed vaccines released through emergency use authorization, because they all work the same way. They all induce high levels of virus neutralizing antibodies. The ones that don't induce high levels of virus neutralizing antibody, but barely reach that threshold, are the Russian Gamaleya vaccines, the Chinese Sinovac vaccine, the Chinese CanSino Bio vaccine. And the reason I say that is because when we're wringing our hands about the South African variant, will these vaccines still protect? The answer is, if they have a sufficiently high level of virus neutralizing antibody, I think even though there's reduction against the South African variant, the mRNA vaccines, the Novavax vaccine, the J&J vaccine, and hopefully our vaccine is still high enough, it'll still protect. It's the ones that have that sort of borderline, barely enough levels of virus neutralizing antibody to protect that I think will fail against the South African one. So, and that's what we've seen with the AstraZeneca Oxford vaccine, not very high levels of virus neutralizing antibody to begin with. And if my premise is right, then I think the likelihood is that the Russian Gamaleya vaccine, the Sinovac from China, and CanSino Bio will not protect against the South African variant. In terms of durability of protection, anybody's guess. Most of these are new technologies. Will they protect for 3 months, 3 years, 30 years? We don't know. And this is why we're going to need a very high level of communication between the federal government and the American people. And unfortunately, right now, the communication is still somewhat fragmented, clearly better than it was in the previous administration. The problem is we're still kind of hearing one-off 2-3 minute interviews between leaders in the Biden administration, whether it's Tony Fauci or Rochelle Walensky or some of the others, and the American people don't get the full picture. So I think one of the big problems that's been plaguing the U.S. response all along is nobody gets out there and says, okay, this is the situation we're facing. Yes, in this case, virus transmission's down. The next huge wave is coming from the UK variant. This is why we need to vaccinate we need to accelerate our vaccination timetable instead of the fall. We need to do this by late in the spring, early in the summer. Here's why we think we can do it, but here's why we think we might not be able to do it, and how we're going to manage that. And that's been kind of troubling to me, is the communications are so profoundly fragmented and uninformative. And that's why last year I just totally stopped watching the White House Coronavirus Task Force, because you never came away learning anything. Every now and then Anne would drag me in front of the TV saying, no, you have to hear this. And I would, but beyond that, I wouldn't. And I think we need to improve our game in terms of how the Biden team is communicating. I think they're doing a good job. Clearly, there's more transparency. At the minimum, they're not trying to create a disinformation campaign like we suffered through last year. But I do think we need that superior level of communication to kind of lay out the framework and really explain to the American people what our goals are. And right now, it's a bit chaotic, and that's leading to a lot of confusion.
That's very helpful. Thank you. I'm going to turn it over to Bettina. The question for you is, how is vaccine administration being tracked? You've talked about how your system is actually identifying at-risk subpopulations to help set priorities, but the actual administration of the vaccine itself, how are we tracking it? And are we able to follow recipients for issues of side effects, long-term health, and how are we getting second doses into people who had the first dose? Is there a system in most states to do that? And finally, how does a doctor know that their particular patient was vaccinated, short of the patient telling them?
So maybe starting with some of the last questions, how do we, individual is reminded of his next vaccination appointment for his second dose when it's applicable? So right now, it's done at the local provider level. So where you receive that first dose vaccination, when you made that appointment online, then you will be, typically, you may receive within minutes of that first dose administered, you may receive a text and email to asking you to set that next vaccination time. So it's at the provider level. So the CDC is monitoring, is tracking those vaccinations, and you can go online on the CDC. There is a vaccination tracker to see that at the population level. It's also done at the local jurisdiction level to a degree. With regard to our monitoring with the Department of Defense on this very large Medicare population, again, it's about 25% of everyone over age 65 we are tracking. We are receiving data from Medicare. Those are claim data. And those claim data are fully coded to indicate first dose, second dose, when those were administered by whom. But CMS is not communicating with Medicare beneficiary to remind them, they could, of that second dose appointment. We are tracking that data with some time lag because claim data are arriving to us with about a 3-week time lag. That can be optimized drastically. CMS is also making use for other disaster scenario, has been making use of what it's called unadjudicated claims, which are claims submitted by providers and accessible in the CMS system within 3 days. We are receiving de-identified data, so we cannot, through the DoD system dashboard, we cannot communicate with individual beneficiary, but we can push back data back to CMS. We can re-identify your data, showing, and communicating directly to Medicare beneficiary according to risk if needed, according to the area where they live. So Medicare, with regard to the Medicare program, this Medicare program can be leveraged. Again, we have leveraged this program in a very meaningful way to access data otherwise missing, to assess risk, to monitor the pandemic, and we are monitoring in terms of safety and effectiveness of the vaccination. We are monitoring infectious rates when those are taking place in between the first and second dose. We are also set to monitor adverse events of special interest, those triggering some medical care, which we will pick up in those claim data. So more can be done. More can be streamlined. The Medicare program can communicate directly with Medicare beneficiary online, via mail, and so forth. I may stop here in terms of this, the state of the vaccination monitoring program in the US now.
Well, that's encouraging a little bit and discouraging a big bit, but those are our current realities. Thank you. I'm going to ask Saad Omer. Saad, let's say that somebody is masked and physically distanced and is shopping in the local supermarket. This is a month ago and nobody was vaccinated. Now let's pretend that people start getting sloppy. There's COVID fatigue. You see people not using masks so much, not physically distancing with the rigor, but you yourself are shopping and you yourself are fully vaccinated. Is your risk higher earlier or is your risk higher later? In other words, if everyone's being cautious, but you don't have any particular immunologic protection, are you better off than having immunologic protection, but nobody is paying any attention anymore? You're on mute.
I was going to mime my way through the answer of the mic. So I think the precise difference between the two is hard to measure because it depends on the specifics. But generally speaking, obviously you're better off having immune protection. But here's the and it's because these are highly efficacious vaccines. But that doesn't mean that we should go easy on or we should completely abandon our other measures. And here's the reason why. The evidence is pretty solid now. The vaccines we are using, the EUA authorized vaccines that we have are very efficacious in terms of protecting the individual who is vaccinated. Where there is a level of uncertainty is whether it interrupts transmission. So your ability to get the virus and transmit the virus, either way. So we do know that it decreases the likelihood once you get, your likelihood of getting the disease, and particularly severe disease. But in terms of transmission, there's uncertainty. Having said that, we do know a little bit about coronavirus biology. We do know about how vaccines work. I'd be highly surprised if there is zero impact on transmission at the population level. I don't think we know what level of impact there would be on transmission, but there is genuine uncertainty in terms of the actual impact on transmission. So once we know, because of that uncertainty, because there is likely to be, we also know that the impact on transmission is likely to be lower than the impact on disease, based on some early data from a couple of vaccines. And so therefore, I think at this point, making sure that even if you're vaccinated, until there is high enough vaccination, not just, one way is high enough vaccination to either interrupt transmission or high enough people who are themselves protected so that the rates of hospitalization and death come down drastically. It's best to continue to take protections so that you're not a vector, even if you're vaccinated.
Saad, I have a question, if I may, Stan.
Yes, please.
What do you think of the data recently published in Israel? So Israel has vaccinated about 1/3 of its population, over 80% of the 60+ who were first targeted to be vaccinated. And I know they implemented other public health strategy with lockdowns, but what they have recently published is that there is a 40% reduction in cases, a reduction in transmission, and 30% reduction in hospitalization. Is that encouraging in terms of vaccination program?
Yeah,
So,
we also had a question on this.
So if I could clarify, the vaccines will reduce transmission. I mean, remember what transmission is. Transmission refers to virus shedding from the nose, mouth, and throat. And the way you stop transmission through a vaccine is if you have high enough, in this case with coronavirus, if you have high enough levels of virus neutralizing antibody, some of it gets into nasal and mouth secretions and neutralizes the virus. And we know that happens because in our studies and other studies on non-human primates, when you immunize and vaccinate, if you get high enough levels of virus neutralizing antibody, not only do you dramatically reduce the amount of virus in the lungs and the lung tissue and the pathology, you also reduce the amount of virus shedding from the nose, mouth, and throat. It's not as Saad points out, it's not as profound as reduction in the lungs, but it seems to be good enough to stop transmission. So almost all the vaccines do that. The AstraZeneca Oxford vaccine in the monkey trials didn't do it as strongly, but then again, the virus neutralizing antibodies was not as high. So I think most of these vaccines will substantially reduce, not completely reduce, but substantially reduce transmission. The problem is we haven't shown it. And that's because the way the phase 3 clinical trial studies were done was if you started to feel sick, you notified the study coordinator arranged for you to get tested for COVID-19. And if you were positive, that counted as a case. And that was the basis for emergency use authorization, reducing symptomatic transmission. Now there's studies underway to actually confirm that it stops asymptomatic transmission. I think it almost certainly will significantly reduce it. And whether or not some vaccines are better than others will likely be on the level of virus neutralizing antibodies. So my prediction would be vaccines that really give whopping high levels of virus neutralizing antibody, like the Novavax vaccine, I think our vaccine, the 2 mRNA vaccines, and if you give 2 doses of the Johnson & Johnson vaccine, I think it will do that. The others less so. So I think the Russian vaccine, probably not. The Sinovac vaccine, the CanSino Bio vaccine. And then again, this gets to this whole idea of giving the J&J vaccine as a single dose. As a single dose vaccine, it's pretty good. It's better than a single dose mRNA vaccine. But if you give 2 doses, it would probably give you more durable protection of immunity and actually more likely to halt transmission. So these things have to be considered. So J&J has 2 phase 3 trials underway. They're going to request emergency use authorization for the single dose vaccine. My own feeling is that the 2-dose vaccine would be more superior. So much for my Yale undergraduate education. Would be superior at not only protecting against disease, but also reduce transmission as well.
No, you're right about that. But the question also is that it is likely to be substantial, but is it high enough to ease up on some of these other recommendations? I take the middle of the road. I think we can ease up on some of these things, but we cannot stop non-pharmaceutical interventions, at least at the individual level.
Oh, of course, yeah.
Like masking.
And again, it gets to what are our national goals in terms of how we want to proceed.
But we should be able to do that, and that's the reward and the payoff of a vaccination program. If high enough number of people are vaccinated, not just in terms of transmission, that's great, that's excellent, but also even if we are just reducing hospitalization and death through these vaccines, that gives us a lot of breathing room to resume a lot of activities.
Yeah, and if you stop hospitalization and death, you also help your homeland security too. If people know if they're vaccinated, they're not going to wind up in a hospital or an ICU that night, that's a game changer. And I think, so the way I think we're on the same page. Our primary goal is stopping death and destruction, but ideally, if we can vaccinate a large enough percentage of the US population and eventually globally, we can halt transmission, and that's going to be very important.
Yeah.
Now let's get back to Bettina's point about Israel. There has been a debate about whether we should do a more blanket single dose with the mRNA, the one that's available now. And, we should have been happy to give nursing home residents, over 75s, 1 dose, and then also vaccinated over 60s, for example, to have a much broader first level of immunity, and then vaccinate with the 2nd dose at a later date. And the UK started to do that, Canada, Israel, and Israel seems to have data that Bettina just alluded to, that at a much lower than herd immunity level, there seems to be a dip in transmission. Now, we don't know because we don't have a good control group. There's not a control country. But does anyone want to speculate whether the FDA and Tony Fauci insisting that everybody get the 2 vaccines was a better strategy than having broader coverage with 1 and getting the 2nd one later on?
I can go. My understanding is Israel is doing a nuanced approach. They're not necessarily going with a 1-dose schedule. They're going with an approach that focuses on getting people vaccinated, not stopping doses for the second dose. So they are giving, and Peter, et cetera, you can correct me if I'm wrong, but that's my impression. And the reduction they have seen is through medically attended cases, which is to be expected if you're having an impact on moderate to severe disease.
You know,
Sorry, I was checking
no,
the numbers,
please go ahead.
and in Israel, so they immunized 1/3 of their population, about 3 million, and 2 million out of the 3 got 2 doses of vaccine. So quite a successful program. Also in terms of vaccination program monitoring, they have a centralized, they have a centralized healthcare system and information system, so they could report back in terms of outcomes readily, which to a degree we can do here with the Medicare program, but that was a big advantage for them.
Yeah, I mean, when you looked at the phase 1, phase 2 data for all of these vaccines, every vaccine developer, including our group, aspired to make a single dose vaccine. You know, when you're fighting a pandemic, there's nothing better, right? That's one of the reasons why the Ebola vaccine was so effective. It was a live virus vaccine. It worked in a single dose, and especially working in a resource poor area like Democratic Republic of Congo, that was a game changer. The problem is this: when we looked at all of the single dose vaccine data, it's not just that it was partially protective. What it really was some people developed really high levels of virus neutralizing antibody after a single dose. Others didn't develop much of anything. So that this idea of partially protective, in my view, what it really means is it's partial protective. The term partial protection is a bit misleading. It's an amortization of the fact that some people are really protected, others are not protected at all. And the reason you give the second dose is it brings up everybody to the same high level. And that's why I'm a strong proponent, along with Tony Fauci, of giving both doses. And you know, the way I say that on TV is, you know, don't play card tricks with the mRNA vaccine. It'll just create a lot of people who get the single dose will wind up going to hospitals and to ICUs, and it'll discredit the integrity of the mRNA vaccines and create a lot of chaos. Also, we don't have that many doses anyway, so the number of people you could incrementally, the number of people that would benefit just by giving everyone a single dose vaccine, given the limited availability right now, is not that much of a game changer. If you want to do anything right now in the US, release the AstraZeneca vaccine. It seems to work pretty well against younger age groups, and you could give that to start interrupting transmission. And I understand we have tens of millions of doses already stockpiled, and if that's really the case, let's get that one out. Remember, these are all transitional measures until we have wide availability and wide levels of supply for all of the vaccines starting in June. So the big problem for the US is how we navigate our way through this very difficult period when the UK variant is revving up. Now we have the South African variant, and we don't have the full supply of vaccines until June, which is one of the big disappointments of Operation Warp Speed. We always heard it was that all of these vaccines were being manufactured at risk, and which meant that as soon as we knew they were working, they could be released in abundance to the public. That turned out not to be the case. And so that's among the disappointments of Operation Warp Speed in terms of not having logistics to vaccinate the American people, is the fact that that vaccination, that manufacture at risk, turned out not to be true. So I think we'll be fine starting in June and July and August. The big issue is going to be how we chart a path to maintain our homeland security, get and maximize supply and output during this very difficult period in February, March, and April.
So that's probably a good segue. We all agree that the number one problem now is a shortage of vaccine. But as J&J, Novavax, AstraZeneca, maybe even Sanofi later on, the Baylor vaccine, as these make their way to market, presumably we will have enough vaccine. So how do we handle the vaccine hesitancy? And I'd appreciate your chatting about, and all three of you are knowledgeable about this topic. I'm working on it a lot. And there is a little bit of a difference. And let me just contrast two subgroups. One subgroup is sort of the militantly individualistic person, the person who says, I never get a flu vaccine and I'm not going to get a coronavirus vaccine either. And I don't want the government telling me what to do. And besides, I think this is a plot between Tony Fauci and Big Pharma to make a lot of money. And that little bit of conspiratorial kind of hyper libertarian view. And then another is, say, a community of color that is skeptical, wants to see more safety data, doesn't want to be an early adopter, doesn't want to be a guinea pig. So would you like to comment? I'll call on Saad first and hear from Bettina and Peter. What about strategies to reach out to people and coax them, cajole them, educate them to be more friendly to vaccination?
So a couple of things. There's a lot of things that can be put in place. I'll mention a few, and I'm sure others will have a lot to add, etc. I know I've had discussions with Peter on some of the things that could work. So the first thing I'll point out is, increasing trust, and trust by ensuring sort of a transparent process, but also, choosing the right messengers, scientist-led communications, and physician-led communications, or healthcare provider-led communication. But before I go further, just to remind you, as you formulated, there are different groups, and as I often say that, there's a group of people who are always going to be who are going to refuse the vaccine. Even if you put mom and apple pie in a shot, they would have refused this vaccine. And they are perpetual. Part of them are Peter Hotez fan club, in the sense that he gets to hear from them a lot more than others, and he's brave enough to sort of face these people on a more frequent basis than many other folks. But these groups, the so-called anti-vaccine groups, are fortunately a much smaller group than a much larger group which is not accepting this vaccine or has questions about this vaccine based on the specifics of the pandemic and specifics of the vaccine. So I'm going to focus again on this group. So first is trust-based communications, which is transparency of the process, but also choosing the right communicators. The second part is that we have known for the last 20 years that the most trusted source of vaccine information is the healthcare provider, even amongst those who end up refusing the vaccine. And that's been consistent. And we need a national CME program that has two prongs. First of all, we know that strong recommendation comes from strong understanding of a vaccine, etc. So buy-in of a vaccine, buying into the vaccine itself. So one component of that CME program should be the actual sort of mechanistic aspects of the vaccine. And the second, it should be evidence-based approaches, such as, I'm not going to go into the details, but presumptive communications and motivational interviewing type approaches. So we tried that after the last outbreak with some success, after the last pandemic in OBs, and now we are working on this kind of a CME that can be scaled up to empower healthcare providers themselves. The last thing is engaging our communities, especially, but not exclusively, communities of color. And the model that some of us are working on is a local expert plus a local validator model. So a local expert, for example, a physician, a nurse grounded in the same community, but paired with a community validator, a church leader, a community leader, a tribal leader, who turns the gaze of the community to that expert, etc., and then replicating that model over and over again. So these are a few of the approaches we can take, and then there's a whole set of approaches we are working on based on mass communication that I'm not going to go into.
Okay, thank you. Bettina, did you want to add?
Yes, I will, concur on all the points Saad made. And even I recall when I was a young public health physician trainee in California, trained to be a public health officer. This was at the time of the AIDS epidemic. And I remember the wonderful leader we had in our county health department, pediatrician, formerly from UCLA, decided to recruit a community leader in the gay community in Santa Barbara County to start an outreach program, education program to that gay community in this county, to educate them about the risk of this emergent disease at the time, which was AIDS. One point though, to address this trust issue, and for this population which are the wait and see, which I do not totally trust this vaccine new and so forth. I would agree that healthcare providers, that physician or pharmacist could be the most trusted communicator. However, many are not accessing healthcare. Interestingly, in this DoD project SALUS cohort we put together for COVID-19 monitoring, if we picked up all COVID-19 cases, we enroll in that cohort individuals who access the healthcare system. That was 25% of the total 54 million population. So that communication campaign, which has been so much lacking, has to be addressed on all fronts. Through healthcare providers, including pharmacies, community leaders in those various communities, PSAs, we have not seen PSAs about vaccination. Again, the Medicare program is a means of communication. People receive email from Medicare reminding them about the flu shot they should get. They have not received email about COVID-19 vaccine because those individuals are at risk. They are getting EOB mailers every quarter. There's nothing about the COVID-19 vaccination. So there are all sorts of communication channels which have to be leveraged on all fronts.
Thank you. One thing that we haven't really addressed are some of the social determinants of acquiring COVID.
So Stan, can I just make a couple of comments on?
Oh yes, I apologize, Peter. I thought
no
we had
worries.
covered that.
Yeah, no,
Go ahead,
I mean,
dive in.
So Saad is a true scholar of vaccine hesitancy. I tend to react with more emotion because I have a daughter with autism and wrote a book called Vaccines Did Not Cause Rachel's Autism, and therefore have been targeted for many years by the anti-vaccine groups. So I tend to react a little more emotionally. I don't know if you remember when President Obama at the White House Correspondents' Dinner, he brought Luther, his anger translator. So it's that's how Saad and I are. Saad gives very measured, scholarly, well-documented responses, and I tend to be out there shooting from what in response. But one of the things that we did, I'm working with a group of social scientists with Texas A&M, including Tim Callahan, as part of our Lancet vaccine hesitancy task force that Saad and I lead. And he did this very interesting study around the two most vaccine hesitant groups. And what was interesting about it was pretty much identical to what the Kaiser Family Foundation did in their survey. And what we found was the two most vaccine hesitant groups were what we called number one, Trump voters, and number two, the African American community. And what's interesting about the Kaiser Family Foundation found was their number one groups, what they called Republicans, and number two is the African American community. So the fact that different methods, different approaches, more or less the same conclusion, makes me think there must be real, that there must be, these two groups are the most vaccine hesitant. So the Trump voter component or / Republicans, what they found was, I think, comes out of this health freedom, medical freedom ideology that really took off in Texas in 2015, 2016. And this has been truly fatal for the American people. In other words, it came out of Texas. I think it started, if you read Saad's papers from 2014, 2015, it started in Orange County around the measles epidemic, and then with the closure of the non-medical exemptions, and then it shifted to Texas and Oklahoma, where it linked to political extremism on the far right, got a lot of backing from Tea Party donors, basically saying, government can't tell us what to do. And it really started expanding in 2020 because what was an anti-vaccine movement glommed on protests against social distancing, contact tracing, and masks. And that's a big component. So one of the things I'm doing in response is I'm going, in addition to the MSNBC and CNN, I'm going on Newsmax and Fox News. And that's a really interesting discussion, which we can talk about. Then the African American community, that one is a bit more nuanced and clearly has these links to historic and structural racism that around the terrible legacy of Tuskegee that ended in 1972, but turns out never really ended. But also we're learning about specific targeting of African American groups by the anti-vaccine lobby that staged these terrible anti-vaccine rallies in Harlem and in 2019. And in response to that, I'm going on African American Black radio stations all over the country, almost on a daily basis now. And it's really been very illuminating for me going on what, is coming to two very different viewpoints, right? The African American community and the Black talk radio shows, and going on Newsmax and Fox News. And it's interesting to see how the two groups are what their big concerns are. For instance, with the conservative groups, when I go on Newsmax, there's this obsession around mandates that somehow the military is going to come and hold us down and force us to get vaccinated. So a lot of the approach to the conservative groups is explaining that it turns out we don't even have enough vaccines to implement mandates, even if we wanted to. And that seems to help a little bit, and then explaining why mandates are not in the foreseeable future. With the African American community, I try to focus a lot on the fact that whereas we tend to talk about COVID-19 as a disease only of people over the age of 65, I point out that in both the Black and Brown communities, Hispanic communities, Native American communities, about 35% of the deaths are under the age of 65. So it's, moms and dads in their 40s and 50s. And, there's no metrics to know whether I'm successful or not. And it's a lot of seat of the pants in how we're doing it. But it is a very interesting dialogue I've been having with the country of late.
That's very helpful. We're running out of time, and I think I'll end with three provocative questions in no particular order. Let me go to Saad and ask you, what is the probability that the world will face another pandemic in the next 20 to 30 years, other than the slow-burning pandemic of HIV or the fast-burning pandemic of coronavirus?
Very high. I cannot, or at least a serious pathogen of pandemic potential. If an outbreak becomes a pandemic, is as much based on our response than as on the inherent characteristics of the virus itself. So I think we are very likely to see a pathogen of pandemic potential in the next 20, 30 years. If I can take like a few minutes to respond to one specific question that was in the comments section. I think it's an important question. I just don't want to leave sort of a false impression. So it was to someone asked me whether when I said that the mortality first strategy is the focus in a lot of places, and that focuses head on reducing mortality, and that doesn't result in interruption of transmission. That's not, and that was the question, did they hear me right? Actually, partially. So what I'm saying is that when you have limited supply, you do not have enough vaccine to interrupt transmission. You need higher level of vaccination coverage to actually interrupt transmission. So therefore, we have 80% of deaths in 16% of people of demographic groups. So targeting that, obviously we can target that sharply, but targeting early mortality, the first few doses on reducing mortality, reduces mortality even before you interrupt transmission. The goal eventually, after you interrupt transmission, as you decrease mortality, is to eventually interrupt transmission to make it sustainable. But that's the whole picture. But the allocation of early doses, it is reasonable to focus on protecting people at the highest risk of death and disease.
Thanks very much, Saad. Bettina, a question for you. Given your work in Project Salus and the collaborations you saw possible, can this be a model for other health policy problem solving across different sectors?
Absolutely. I think when this Project Salus started, the military had a mission. They had to support, in an emergency hospital in distress, etc. They needed data which were not there. And they set up an example on how to go about having a working platform. They call what they say the best of tech. They gathered over 90 sources of data because our data system are dispersed, and that's the information that was at your fingertips. So anyway, what Project Salus has built as a true public-private partnership, reaching out to data scientists, engineering, existing platform, and reaching out to other sister agencies like CMS and of course the CDC. So they build a platform which can be readily applied to any emergent disease. As Saad say, the likelihood for us to face another pandemic is really high. And we learn all sorts of lessons. And so there is a working platform which can be readily applied. So we pull data from claims. We can pull also data from electronic health records, the VA system, and so forth. And this is one example where it has to be a whole government approach. Government federal agency cannot compete. They have to use what has been developed, which has proven itself. Interestingly, we are making our first presentation tomorrow before the White House Coronavirus Task Force. And we had made 2 such presentations, with the prior administration without success. So I'm pretty optimistic that things are going to change here with the Biden administration. And so anyway, that was a long answer to say yes.
No, that's great. Thanks. And Peter, we've got an unusual question for you to end your evening with. People are very curious, including myself, I might add. What are 2 or 3 takeaways from your 2020 year as a functional public educator and public spokesperson? You've had the media platform so many times, and we're all curious. What have you learned in this unusual year that you've spent in the public eye?
So this will surprise you, Sten. The answer is one of the things I learned is that Yale University gave me a moral compass. What do I mean by that? Well, having all that experience going up against anti-vaccine groups, I know what anti-science disinformation campaigns look like, and starting as bad as things were, insisting that the states take the lead, there was no federal response. I was critical of that, but then I started to see unravel in April and May of last year a deliberate disinformation campaign coming from the White House. And they were downplaying the severity of the epidemic. They'd commissioned the Koch brothers to fund this phony Great Barrington Initiative. They had they discredited masks. They said the hospital admissions were due to catch up elective surgeries, and the list went on and on. And I said, I've seen this before. you know, having gone up against anti-vaccine groups, I know I can smell a disinformation campaign a mile away. So I had that. And then I had my bosses saying, you know, Peter, you know, you can't go into that space. You got to stick with the science. You got to stick with the science. And, you know, and my wife, Ann, you know, said, you know, this is tearing you apart. I can see this. And just remember, as the deaths start to mount, 6 months from now, if you wake up and realize you haven't done everything you can to stop this, you know, you won't be able to live with yourself. And that's, you know, that Yale moral compass really can. There's a reason for reading the Greek tragedies and reading the Divine Comedy of Dante and Homer and Virgil, because that's what Yale does for you. And so I was able, so I finally said, look, you know, I suddenly realized it wasn't that I was politicizing things. I didn't politicize it. Those guys did, by intimately linking an anti-science campaign to a political agenda, and it happened to be on the far right. So then I went after it, and it was the right thing to do. And I think I was among the first to label this as a disinformation campaign and point out why it was a disinformation campaign and why we can't tolerate it as a nation. And it was tough, right? Because, well, first of all, you know, especially being here in Texas, where the, you know, the cities are very liberal, but the state legislature is extremely conservative. This was tough going, and you can imagine the hate mail, as bad as it was when I was going up against anti-vaccine groups. I'd never seen anything like this. So this was a tough space to be in. And again, having that foundation from Yale, I think, made a difference. And I'm still having this issue for a different reason, because now what I'm doing is making recommendations for the Biden administration to do things that are not doing. And it's also interesting, coming from the far left, the fact that I'm not falling in line lock, stock, and barrel is seen as a betrayal. And the statement is, you know, this is so different from what we had under Trump. And it's actually, I say it's true. There's no disinformation campaign. There's transparency. There's no deliberate intent to deceive. But on the other hand, there are things they're doing. There are things that are not doing they should be doing. And that, you know, and you see this play out on Twitter, of course. This is seen as some kind of betrayal as well. So it's not easy doing this. And all I can say is, you know, having that there is an advantage to having a Yale education, because it can help you weather some very tough times.
Thank you for that. That's a great way to end our evening. I want to thank this distinguished panel. There were a lot of issues discussed tonight, a lot of issues that were not discussed in detail. We just haven't had time to get into social determinants of disease, for example. Many things we would love to have more time on. So at least we talked a little bit about government healthcare policy and the science of the vaccines, communication issues, some of the lessons learned to date, and ultimately millions of people are going to have, tens of millions, hundreds of millions of people are going to have to decide that they're willing to take a vaccine, and we're going to need to make it easier for them to access those vaccines. And I think that's a tremendous challenge that we're facing. I remember that the first play I saw at the Yale Repertory when I moved to Yale almost 5 years ago now was An Enemy of the People by Henrik Ibsen. And back in 1881 or so, he was writing about the fictitious Dr. Stockman, who had recognized the poisoning of the spas in the fictitious Western Norwegian town. And he spoke out, he spoke truth to power, and paid a terrible price for doing so. And yet the playwright was trying to send a message as to how utterly critical it is that scientists, public health professionals, health providers are guided by the science and are not having their viewpoints distorted by other considerations that may be more in the financial or political arena. So I happen to know that Bettina and Saad and Peter are all cut from that cloth, and I want to thank all three of you for bringing your expertise, for your deep caring for humanity to help us solve this global challenge. I'm happy to turn it back over to Joellen Gray.
And I too want to echo a deep, deep thank you. I know that we will be watching all of your initiatives over the next couple of months with our fingers crossed, and look forward to working with you to ensure success in all of this. Thank you so, so much.
Thank you all.